Welcome to AETCM, the Emergency Medicine Channel. Sir, can you start?
Yes.
Today we are discussing about a 54-year-old female who came to the emergency with complaint of acute onset tiredness or weakness. Sir. On initial arrival, the 10-second assessment patient was conscious, talking in full sentences. Sir. So we started with the primary survey. Airway was patent, no secretions, and C-spine was normal. Breathing, bilateral air entry was equal. Respiratory rate was 16 per minute with saturation of 100% on room air. And circulation, BP was 110/70 with pulse rate of 80 per minute. With disability of GCS E4, V5, M6 and pupils 2 mm bilaterally reacting. And temperature was 98.5 degree Fahrenheit. Primary survey was completely fine, so there was no any difficulty in that. So as patient was complaining of weakness, tiredness, we had taken a GRBS. Even GRBS was 150 mg per DL, sir.
Okay.
So the primary survey done. Now coming to the secondary survey, 54-year-old female, she had complaints of cold for last 2 days with fever and dysuria since today morning, sir. And when she went to the job today morning at 10 a.m. onwards, she started feeling tiredness and giddiness. As per her co-workers, she had been complaining of right-sided compared to the left side, she had been complaining of weakness. So in view of which the co-workers brought her to the emergency department. So coming to the examination component, comparing the GCS was full and the higher mental functions were all normal. And comparing to the power, right upper limb, lower limb, both were equal power. Everywhere 4/5 power was the tone was normal, sir. No any appreciable objectively any weakness or anything was identified. But as she was complaining of subjective feeling of difference in weakness, we went ahead first with radio imaging of MRI, brain contrast with MRI angio. So once it was done, there was no any acute infarct or any weakness in the same.
Okay.
Next, as she has complained with fever and dysuria, we were suspecting an UTI and we have sent urine report along with the complete blood counts were sent, sir. The urine report showed 4 to 8 pus cells, sir, and CRP was 11.8 with WBC.
Normal urine WBC count in female?
Normal WBC count 2 to
female patient. 2 to 6. Is it normal or abnormal, this one? 5 to 8 pus cells, RBCs in female urine is normal or not? Especially in elderly individual. It's mostly normal. Because most of the patients, even cells itself can be picked up by pus cells in a normal individual. If the patient is having symptoms, then that should be treated. Or culture is positive, it should be treated.
Here the counts were elevated, so 15,000 was the WBC count, initial count, but CRP was 11.18 with granulocytes of 82.8%.
Okay.
So we started with IVs, injectional antibiotic of ceftriaxone was started in UTI. Apart from that, in general workup, she is a known case of hypothyroidism and hypertension. Sir. Hypothyroidism, she had been taking medication for 2 years. She had taken 8 years ago. She had taken the treatment and she has stopped taking treatment further. So we had worked up about TSH regarding the same. Sir. TSH was 17.10 with free T4 of 0.70.
Okay.
And we high TSH with low T4, so primary hypothyroidism was suspected in this. As it's a known case of that, we started supplementing with Tyronome of 25 mg was started orally, OD dose of it. So. And regarding she after the 1 day admission duration with IV fluids and antibiotics, she started feeling better and her weakness and tiredness has reduced.
Okay. Urine culture?
Urine culture was censored with no growth after 48 hours.
Okay. Normally, this urine pus cells in a female patient, 5 to 8 cells, should not be considered as urinary tract infection unless only she is having a proper symptom like dysuria, lower
complaint of dysuria was explained by her.
Okay. So this is a case of hypothyroidism, which she was discontinued the treatment and now came with weakness. Okay. So what do you mean by primary hypothyroidism? What do you mean by secondary hypothyroidism?
Primary hypothyroidism, clinically lab-wise, primary hypothyroidism would be having high TSH with low T3, T4, whereas secondary hypothyroidism would be all TSH, T3, T4 all are in lower.
Lower limit. Okay, there is no elevation in the TSH.
Secondary hypothyroidism is cases where the pituitary and the hypothalamus from that origins.
Isolated hypothyroidism is not very common in secondary cases. Okay, how do you start treatment in this type of cases? We have started only 25.
Initially, age less than 50 years and with no any cardiac history, we start with 25 mcg of Tyronorm. We will be replacing the T4 with Tyronorm, and after 2 weeks.
Tyronorm is a brand name.
T4, levothyroxine.
Okay,
levothyroxine. We start with levothyroxine, and after 2 months, we repeat the labs and we check for the TSH level. If the TSH level is still high, we can increase the further dosage, and we try to reach that equilibrium. Okay. Once it is reached, every yearly basis we can adhere.
Why in old age we are starting in a lower dose?
To avoid any cardiac arrhythmia.
Cardiac arrhythmia?
Cardiac, like it can cause palpitation, higher thyroid.
The most important reason is whenever your metabolic activity increases, your heart rate, like you told, heart rate increases. These type of patients are prone to develop ischemic heart disease. So that's why we are not starting very high dose, but you start a lower dose, but you have to build up the dose to 50 microgram, 75 microgram, 100 microgram. If a patient come with hypothyroidism is on treatment, suddenly she is admitted with a sepsis or something like that, what do you do?
In that condition,
suppose this patient is taking 75 microgram, she is admitted with sepsis. What is the immediate step you do?
We continue the same.
Continue is correct. So better to increase the dose, at least 25 microgram to be increased, because the requirement of thyroid hormone in a stress condition will be always physiologically itself it is high.
Yes.
We know that. So if the patient's TSH was previously normal and suddenly she is admitted with a sepsis, it is better to increase the dose at least by 25% of the existing dose. Okay. So what is the TPO? Some patients you do TPO also.
In the cases where the...
Here we have not done it because it's already known case of this one, she discontinued.
As per the algorithm, once the TSH is high, then we see the free T4 level. If free T4 level is normal, then we call it a subclinical hypothyroid. If T4 level is low, then we consider it to be hypothyroidism and we evaluate further whether it is an autoimmune causing or the other causes. Autoimmune causing hypothyroidism is identified by anti-TPO antibodies being present in the blood.
Okay. So many patients in ICU can see their TSH is 5 to 10 and TPO is positive. What is the action to be taken in that condition?
Actions. We need
TPO is positive means what?
Autoimmune
thyroiditis, and patient is going to develop hypothyroidism. So at present they are in subclinical hypothyroidism, but later they will definitely develop this one. What are the indications for treating these type of patients who is in subclinical hypothyroidism?
Symptom.
One is symptom. Symptom means it is not subclinical. Yes. It is clinical. Patient TSH is slightly higher, like 7, 8. You see many patients in ICU, 7, 8. But there is no symptom. When will you start Tyronorm or your triiodothyroidine? One is TPO positive.
TPO, okay.
Other one is high cholesterol, obesity, daytime sleepiness, lethargy, weakness, and cardiac events like patient is already having coronary artery disease. All these things. What are the associated features of hypothyroidism? Here the patient is presented with
weakness as the major thing.
And what are the common presentation to your ER with hypothyroidism?
They can be having cold intolerance. Next,
weight. Not a presenting feature.
Weight gain with not.
No, I am asking about emergency medicine.
Emergency, sir, mixed edema.
Okay, the most dangerous complication is mixed edema. But other complication which you might have seen.
Dryness of this.
Hyponatremia is one of the most important presentation of. That's why every patient in hypothyroidism, you can see some patients can have hypothyroidism. That may be due to the dilution of the fluid. Yes. Okay, hypothyroidism is the most common thing. Other than that, you told what it is? Mixed edema, How do they present?
They can be comatose patients with puffy edematous face, with non-pitting edema of the leg.
I'm not asking medicine. I'm asking only emergency medicine. How do they present? When will you suspect? One is coma. That is correct. All comas, you don't make a diagnosis of hypothyroid coma. You are seeing many coma patients.
Hypoglycemia with hyponatremia.
One is hypoglycemia, hyponatremia, coma. Then, most important thing you are not telling. That's why I'm asking.
Bradycardia.
Bradycardia, hypothermia. Okay, so these are the important findings. Bradycardia with hypothermia. What is a typical ECG finding of mixed edema coma? ECG finding, you should know all these things. Hypothyroidism itself, you can see this. What is the finding? Bradycardia is already told. One more finding is there, that's why I'm asking. Osborne wave is in hypothermia, you can get Osborne wave. Low voltage complex. Okay. So any low voltage complex with bradycardia, you have to suspect pericardial effusion because of hypothyroidism. Whereas it is tachycardia with low voltage complex, it is due to all other cause of pericardial effusion. Okay, so pericardial effusion, cardiomyopathies, diastolic failure, coronary artery disease, coma, hyponatremia, hypoglycemia, these are the common presentation to emergency room. How do you manage that type of conditions? Like this patient's TSH is very high. She is about to develop a mixed edema state now. But before that, we could start the treatment. But if she come to emergency room after developing coma, how do you manage?
So initially, we need to take the primary survey. We need to do the required things like protect the airway. If the patient is having low GCS, then we protect the airway.
What airway problems you can anticipate in this type of patients?
Being low GCS, so they'll not have the
aspiration. What happens here?
Edematous, it becomes.
Edematous. Okay. So mixed edema will be there. Here also there will be infiltration of myxomatous material there also. So you have to anticipate there will be some difficult airway in this patient then.
Next, coming to the circulation, like hypotension related, like bradycardia related, we can start with atropine.
Atropine?
Bradycardia, hypotension. If the patient is in...
if the patient is having, suppose, mixed edema coma, hypotension, shock, what is the treatment? Atropine or something else?
Steroid.
Steroid
is the first line of
treatment. Atropine can be given according to ACLS, you have to give atropine to increase the heart rate. But we should know that that is not the reason here. The patient is going to this state.
Here in this case, steroids are initial treatment of mixed edema coma would be steroids and replacement of free like levothyroxine, 400 mcg initial start dose to be given, and then tapered off the next day to 200, then 150, and then convert into tablet dosing.
Okay. There is no IV available in our country. What do you do? IV is not there. Oral is only available in our country. So there is no need to go for IV preparation because that is not available. You can straight away go for oral. Both bioavailability is same. Okay. Then?
And then we need to consider about the hyponatremia and the dilutional hyponatremia, which the patient usually will be having, and hypoglycemia component.
Okay. So what happened to this patient afterwards?
In this patient, as the patient developed, improved their weakness and tiredness, we had discharged with tyranome 25 mcg as of now to follow up after 2 months with the TSH values to titrate the dosing.
Okay. So what you understood from this case, these are very common scenarios in ICU. You get many patients, TSH values are either above 5, sometimes above 10. So treatment, we have to decide whether to treat or not. Yes. So subclinical hypothyroidism, many patients may not require treatment at all. But if they have some of the findings like high cholesterol, obesity, increased sleepiness, coronary artery disease, pregnancy, TPO positive, then you have to treat. Here, it's a clear-cut case of patient has missed the doses of thyroxine, and we have to initiate the dose. Only thing is, when the patient is elderly, we have to be very careful in initiating the dose. Okay, so slowly you have to build up the dose. You need to wait even for 2 months. You can increase after next week itself, you can increase that. So we are having the preparation in 25, 12.5, like that. Smaller preparations are available now. Okay. Anything else you want to add? You want to add something? Nothing.
Half-life of this is actually 7 days.
Okay. Which
So
one?
levothyroxine.
Okay.
So even if patient misses 1 day dose, immediate next day twice the tablet can be taken
Okay. So when will you advise the tablet to be taken?
in the morning time. We prefer
Before food or after food?
After.
Empty stomach.
Empty stomach.
So empty stomach, they have to take at least 1 hour. They should not take any food, and every day they have to take to test the TSH. What are the pre-requirements? TSH.
Early.
When will you test? Suppose this patient is coming after 2 months for testing. What will you ask? Will you ask? One question you have to ask. What is that question? He has already told that. What is that? Last 1 week, you have taken the tablet properly or not. That is the most. If the patient has not missed 1 or 2 doses in the last 1 week, don't take this one. Okay, that is very important. What is the target TSH?
Target TSH is 1.5 to 4.5.
No, that is a normal value. In this patient, if we come for follow-up, you only
It should be lower than the present 17. It should be downtrending.
How much?
How?
How much should be low? It should be towards the lower
lower
half
range.
of the normal. Suppose it is 0 to 4, it is less than 2. Suppose it is very low, what is the common side effect? Most important side effect is what?
Palpitation.
Palpitation. Sometimes patient can develop. If tachycardia is there, palpitation can happen. Before that, what is the common
Sweating.
What is the common side effect of subclinical hyperthyroidism?
Hunger, continuous eating. Active.
Osteoporosis. Osteoporosis. So any patient who is having lower limit of TSH, always try to give some vitamin D, calcium, all these things. Okay, so like this patient will already have some vitamin D deficiency, hypocalcemia, because she is elderly. So whenever she come for follow-up, we have to add calcium and vitamin D. Okay. Okay, thank you.